provide insights into the significant changes and trends in Egypt's population dynamics over the past 3 decades. This session features our distinguished speakers, Professor Abla Alalfy, Deputy Minister of Health and Population, Dr. Sameera AlTuwaijri, Global Lead, Population and Development, Health, Nutrition and Population, the World Bank, Professor Hala Youssef, Sexual and Reproductive Health Advisor, UNFPA Arab States Region, Professor Dr. Timothy Evans, Director and Associate Dean of the School of Population and Global Health, Faculty of Medicine, McGill University, and Associate Vice Principal, Global Policy and Innovation, and Dr. Judith Bruce, Senior Associate and Policy Analyst at Population Council. This session will be moderated by Dr. Magdy Khaled, Consultant of Family Planning and Reproductive Health.
Good afternoon. While we are 30 years from the International Conference of Population and Development, ICPD Cairo 1994, Egypt now is launching the second version of the Global Congress of Population, Health and Human Development. The National Population Strategy 2023-2030 with the human rights dimension was launched in 2023, and recently an acceleration plan was introduced to enhance the achievement of the replacement level of fertility. Within this context, we will start this session entitled Population in Egypt, 30 Years Journey from 1994 to 2024. We have 5 distinguished panelists, and the first panelist supposed to be Professor Dr. Abla Alalfy, but kindly and generously, she wanted to give the time for other speakers, so she is attending with us, but she is not going to present. So may I call on the first speaker, will be Dr. Sameera AlTuwaijri. Dr. Sameera AlTuwaijri is the global lead on population and development at the Health, Nutrition and Population Global Practice with the World Bank. Dr. Sameera has a PhD in health policy from Johns Hopkins. Please, Dr. Sameera, the floor is yours.
Thank you, everyone. Good afternoon. And thank you for being here at the end of the day. I have a couple of slides. Yes. All right. So when I started thinking about this, when I started thinking about this, it didn't come off as what does it cost to have family planning? I rather thought about it in terms of what is the yield on reducing fertility. So I designed my presentation as such, and I just wanted to mention 2 points before I dive into my presentation. The first thing is that looking at the yield or the dividend on the economy does not negate the rights agenda. I think the fertility, the entire reproductive health agenda is anchored on the rights of women and girls to choose when and how many and with whom they are going to have children. So this is a complement to the rights agenda before we get criticized for being, the World Bank talking about reducing costs. That's the one thing. The other is, I think we in the reproductive health community spent a very long time and a lot of efforts advocating for the rights agenda. I think in that, of course, we gained a lot and we covered a lot of mileage, but at the same time, I think we overlooked the ministers of finance, so those that actually decide the public expenditure review or the assignment of costs to different programs. So I think this is sort of a complementarity to what and how the costs can be actually measured. So reducing the total fertility rate, which is by definition the average number of children born per woman, can lead to a lot of good gains for the government and also for societies. The first one is that it does reduce the demand on public services, and this is just a sort of a volume issue. You know, the less people you have on the social services, the better the social services are. And it also does improve the economic productivity. It does lower the dependency ratio, which is both an economic and epidemiological argument, and also impacts the environment and the resource savings, and leads eventually to long-term economic growth. Now, the potential gains from fertility reduction can be summarized in this slide, and I need to look at the bigger version of the slide. So if you look at the high fertility, medium fertility, and low fertility scenarios, and the ratio of children and working age population by percentage, then these are the three lines that you see on the left side of the slides. And then on the right hand is the real GDP per capita, the gross domestic product per capita, as constant in 2007. You could see that these different fertility scenarios have different impacts on the GDP, between 20 and 50% going through the fertility decline from high to medium to low fertility. Now, what are the potential gains for fertility reduction? And this is again not a repetition of what I said 2 slides ago. It's rather some unpacking. So there are direct effects in the fertility reduction that actually do increase over time. So there is a cumulative index of these. A faster decline in the total fertility rate would yield a sharp increase in the potential for income per capita growth, because there are more favorable population age structure. So here, it's not just the population number, the population volume or size, it's also the population characteristics that actually come to play. Including also the indirect effects, which would impact even larger, and those are declining child dependency ratios. The less children we have, the higher we have, the lower we have in dependency ratio. And this is positively associated with increase in spending per child. So again, it's a numbers game, not a zero sum, but it's a numbers game. Less children, more resources per child, and so on and so forth, leading to actually better human development outcomes and human capital accumulation outcomes, and also higher productivity, because the idea of the entire demographic transition and dividend is to have a healthy, educated children who will become healthy, competitive, productive adults, and age to become healthy, aging, and independent and dignified older people. Now, the successful policies also would amplify the impact even more than all of this. So increasing the labor force participation, especially for women, and wherever we go, at least in our region, the female labor participation leaves much to be desired for many reasons. I think it's outside the scope of this discussion. Would increase also the labor supply and further increase the growth impact. So it's all not just about the increase or decrease or the impact on the GDP in dollar amounts. It's also the long-term effects on the social services, as well as the competitiveness in the labor market. Now, this is also another couple of graphs. So we're comparing here Egypt to South Korea. South Korea's total fertility rate declined faster than the pace that we have seen in Egypt. Now, the TR difference increased from 0.8 to 0.1. So as you can see, this is the fertility scenario. And then this is the linear or the timeline that all of these things happened. On the other side, there's the GDP per capita, which grew 298% in South Korea compared to about 26% in Egypt. I think the moral of this slide is that it's not just the reduction in total fertility rate, it's the pace with which this decline actually happens. Because if it happens too slowly, the impact is negligible. If it happens too fast, there are, of course, other ramifications, but this is what it does to the GDP or the economic gains. So while Egypt has actually shown progress in decreasing the total fertility rate, it's missing to a great potential of economic gains that can be made through change in the age dependency ratio. And again, this is probably has very little to do with the demand and supply for contraceptions, for example. It really does have a lot to do in the productivity and the competitiveness in the labor market. So without interventions on the left-hand side, that the TFR will slowly reach around 2.4 by 2040. I know this is not what you want to hear, Dr. Abla. I get that, but we're just talking about scenarios here. Compared to the ability for the TFR to become 2.1 if we have the right interventions, if the right interventions are actually introduced. And the three lines, the green, the yellow, and the red, to show you these different scenarios. Accelerating the fertility decline to reach a TFR of 2.1 by 2040 has the potential also to decrease age dependency or dependency ratio by 10%, which has a great implication for the GDP per capita, which takes us back actually to the numbers games, like more people, more services, less people, less services, and better services. So again, in 30 years, Egypt can make a cumulative gain of almost 208 trillion Egyptian pounds in GDP through accelerated fertility decline. We've shown this slide sometime this week, and it does show what is actually the impact of the reducing fertility, less population size, and more favorable population characteristics. You have a cohort who is working and productive and not dependent on anyone. The same happens for the elderly as well. So if the human capital index gap is closed immediately, the global GDP per capita would be 38% higher by 2050. A similar effect can actually be expected in Egypt because Egypt has the same indicators. So these targeted interventions and increase in average GDP per capita also would impact the poverty headcount that would significantly decline, plus other social indicators. I think this is my last slide. So the difference in population side also has a large implications on public spending. And Egypt can save almost 2 trillion Egyptian pounds over 30 years. So this is just the public spending. And there's a lot that can be said about the public spending besides the social services, infrastructure, roads, schools, and everything else. So if the public spending increases exponentially with population increases, then there is a large potential for savings. Again, in 30 years, according to the other graph, Egypt can actually make that much saving that can be added into the social services of housing, health, and education with the accelerated fertility decline, which goes very well into the accelerated plan that is a direct translation of the population strategy in Egypt. Thank you.
Thank you. Thank you, Dr. Sameera, for this exciting presentation. I have a question for you, but at the end of the discussion. So we will keep it at the end of the discussion, at the end of the presentation. Now, may I call Dr. Tim Evans. Dr. Tim is the director of the School of Population and Global Health, McGill University. Over the last 25 years, he has been a leading figure in advancing global health equity and strengthening health system worldwide. Dr. Tim, please.
Thank you very much to the organizers of the meeting, Government of Egypt, and the Deputy Minister of Health and Population for organizing this panel and having the privilege to speak on it. To my distinguished co-panelists and people in the audience. I opened my remarks yesterday by mentioning a great mentor of mine, Dr. Mahmoud Fatala, who has been deemed the father of safe motherhood. Those who may have known Mahmoud, like I did, would have always admired his oratory skills because he always talked in sequences of 3. And so I will try and follow in the steps of my mentor and make 3 points. Now, Mahmoud had a very strategic way of managing his 3 points because under each point, he would add 3 points. And so, therefore, he was able to fit in most of what he had to say. So I'm going to talk about global health. And given that I'm one of the older members here, I'll take us back to 1978 and the Declaration of Alma-Ata. I'll talk about 30 years after Alma-Ata in 2008. And I'll talk about 30 years after the famous meeting here in Cairo in 1994. So first, the reason I thought it would be important to invoke the 1978 Declaration of Alma-Ata is that first, the context at the time was of the Cold War. UNICEF and WHO convened the meeting in the former Union of Soviet Socialist Republics. And in doing so, the United States of America boycotted the meeting. And the resourceful Director General of the World Health Organization at the time, Halfdan Mahler, recognizing that it was important to preserve some global balance, invited Senator Ted Kennedy to come in his personal capacity to the meeting, which he did. And Halfdan Mahler, the Director General of WHO, put Senator Kennedy right beside him at the table so that every picture taken in Alma-Ata, the USSR, would show that there was a very significant US presence and therefore balance that. And I mention that because I think leadership internationally, and I think it was certainly present in 1994, needs to balance political forces in a way that you can find consensus and move agendas forward. And that was done, I think, despite the odds in Alma-Ata. There were 3 points in the declaration that I think are really important that came out. First in the declaration were values, and they endorsed the values of the Constitution of the WHO, health as a fundamental human right, without distinction to race, socioeconomic status, or place, or gender. Secondly, it defined health as a complete state of physical, mental, and social well-being, a definition that actually was reproduced in the ICPD declaration in 1994 with a focus on women. The second area of the declaration that bears attention is that it pointed to the importance of systems as being the motors for moving forward and on the values. And it talked about the importance of frontline workers, community health workers. It talked about the needs for essential drugs and appropriate technologies. And third, it talked about the need to decentralize, that not everything could be done from the capital, that you had to give real leadership in a decentralized way. So that system savviness was very much part of the declaration. And finally, the primary healthcare declaration identified the first global goal in global health. And it was a very modest goal of health for all by the year 2000. And I think it's important that we recognize that prior to that time, there had never been any consensus on what it is the world wanted to achieve in health. And that was a very ambitious goal, which we ended up not making, but I think was part of what has transpired since. So that's my first point related to the 1978 Declaration of Alma-Ata. Second, 30 years after Alma-Ata, and I mention this in part because the goal of health for all by the year 2000 was not achieved, but we moved into another era of the MDGs, and 3 of the 8 MDG goals dealt directly with health, one specifically dealing with maternal health. And at the time, I was working with the World Health Organization, and the Director General requested me to write a 30-year update on primary health care. So together with colleagues, we wrote a World Health Report entitled Primary Health Care, Now More Than Ever. Now, using my Mahmoud Fatala rule of threes, I'm doing a little bit of revisionist history to say there were 3 primary reforms recommended in that report. The first was that we really need to move towards universal health coverage based on prepayment systems rather than pay-as-you-go that deliver people-centered services. So that was the first driver of the reforms. The second, as a very important complement, was to strengthen population-based reforms, public health, and conditions that allow people to achieve health that are not limited or specific to clinics or hospitals. And the third was that you needed leadership. Leadership that walked the talk on core values like equity and dignity, that was knowledge-based and was investing in what we didn't know and what we needed to know. And third, that was both participatory and pluralistic. And I think that third reform of pluralism in leadership is particularly important, in part, and perhaps not completely unrelated. A year later, the first female Nobel laureate, Elinor Ostrom, in economics, won the Nobel Prize, and she won it for her theory of polycentrism. So that's my second point related to what we tried to move forward as reforms in global health around primary health care now more than ever. My last and third point is to think with you about 30 years after the famous ICPD here in Cairo. The context is that we're nearly 2/3 of the way through the SDGs. We have 1 of 17 goals focused exclusively on health, and we have SDG 5, which focuses on women and gender equality. We have a very complex context, which is can be described as being post-pandemic, poly-crisis, and political polarization. Not easy. We have a brave new world of global health, where every country faces complex health challenges, from infancy through to aging populations, from under to overnutrition, from infectious to which express themselves along fault lines, social fault lines, that are very difficult to manage. And these fault lines often lead to the movement of populations across borders, which become collective challenges that we need to identify and figure out how to manage, not on our own, but with respect to other partners. Every country has very similar shortfalls in system performance, whether you're rich or poor. You have insufficiencies, you have inequities, you have inefficiencies, and perhaps most importantly, you have growing impatience from populations that have expectations that the public sector will deliver, the government will deliver the services that people need. Again, tough conditions in the brave new world that we exist. So let me finish by making 3 humble suggestions such that we might be more fit, FIT, for purpose moving forward in population and global health. So the FIT is an acronym, and it relates to finance, information and innovation, and training. So with respect to finance, we need to generate more money for population and health. 3 suggestions. 1, build on the investment case of human capital and human development, because that provides both the instrumental rationale that you're going to strengthen the well-being and the welfare of society, and the intrinsic rationale that you invest because health and well-being are so important as areas that society needs to invest in. So first is strengthen the investment case. The second is to focus much more realistically on domestic resource mobilization. And on this front, I think we have to move beyond what I call the 3 Bs. The first B is what I call the Benjamins. That's the Benjamin that you find on the US dollar, and that is the pay-as-you-go system. Pay-as-you-go is most inefficient and inequitable way of financing services like health. Second is we need to move beyond both what Bismarck suggested as the social health insurance system, as well as what Beveridge recommended with respect to tax-based financing. And it's not that there isn't a role for social health insurance and for tax-based financing. It's just that we have to embrace the reality that in this day and age, economies are more informal than they were 40 or 50 years ago. And informal economies don't lend themselves easily to social health insurance or taxation. So I think we have to address that reality much more frontally and say, how do we, there's a lot of money out there, but how do we pool that in ways that we're going to have progressive and systems that promote access? The third area on finance is with respect to global resource mobilization. And here, with due deference to a former Prime Minister of Canada by the name of Lester B. Pearson, in 1969, 55 years ago, he led a World Bank commission called Partners in Development. And out of that commission came the famous 0.7% that all countries should give to development assistance. Well, 55 years later, Canada, the country whose prime minister recommended this 0.7%, has never come anywhere near 0.7%. And very few countries have. Some have, and good for them. However, there's a real question, given that the primary objective of the Partners in Development recommendations was something called Development for All by the year 2000. Does that sound familiar? Development for All by the year 2000. That was 1969. 1978, WHO stole the intellectual property of that commission and called it Health for All by the year 2000. However, we didn't achieve development for all by the year 2000. So the question is our development financing architecture really fit for purpose? And I think given where we are at the moment, it's time for a rethink and fresh thinking to try and tackle the complex challenges that we have. So that's finance. The second area is with respect to information and innovation. To me, it's a travesty that in the 21st century, in 2024, literally thousands and thousands of young children are born every day without any identity. They fall outside vital registration systems. And if children are not counted, they don't count. That's the simple truth. And there's no reason technologically why every attended birth shouldn't be registered and recorded, both in terms of the outcome of the child and the outcome of the mother in real time. So population, let's secure those foundations, those critical foundations of registering life when it arrives in such a way that we get real denominators and understand the big picture, particularly with respect to communities that currently aren't counted. The second area in information and innovation is really that we need to embrace the digital and information age much, much more proactively. And I think there's an opportunity to have real-time epidemiologic, demographic, and economic variables being collected in such a way that we could launch a new discipline called epidemiologics. So that's a joke, epidemiologics, but it's the idea that, in fact, if we put a lot of the young talents that are emerging from our universities and said, design a real-time information system that is going to give us the pulse of what's happening on human development. My guess is they could create systems that would inform and provide the evidence to reform policies in real time. My last suggestion on information innovation is that we need to think about investing in research and innovation systems in new ways. Not only do they need money, no country can afford not to invest in research and innovation, but we need to think about getting and encouraging research and innovation in the places where it's needed most. And so often, those are not tertiary care hospitals in capital cities, but actually difficult to access communities living in difficult circumstances where researchers may not be so comfortable going. So we need to redirect systems to make sure that those with the greatest health problems get the most research attention. My last suggestion on this front, after finance and information, is training. And on this front, I think it's very important, particularly with respect to this agenda, to recognize three things. First is the massive importance of women as caregivers in our world. In every society, they are the primary caregivers, and the value of that care is consistently underestimated everywhere. We need to recognize it because it plays a massive role in the well-being of our population. Second, midwifery, a huge opportunity, yet we still have way too many midwives who are absolutely essential for the front lines. we need to be much more aggressive in scaling up this critical dimension of the workforce and doing it in such a way that it's innovative and community-based, so that those that are trained are from the communities that need those midwives most.
Time, please.
And my last comment is with respect to the need for institutions to rethink the training of health workers so that they're not simply technicians, but they're much more effective problem solvers equipped with transformational competencies to lead change to complex problems. If we leave all of the change to the government, then the government will never manage. But if we have empowered health workers who are able to address problems on the front line, then they will be very helpful to making all policies successful. So with that, thank you very much for your attention.
Thank you, Dr. Tem, for this very interesting presentation. I think these suggestions will be very important for us, and especially those about the health insurance. May I call the third speaker, Dr. Judith Bruce. She is International Population Council. She joined the International Population Council in 1977. She is the senior associate and policy analyst. She was among the first to illuminate the scope and negative impact of child marriage and violence. Please, Dr. Judith.
10 minutes.
Thank you very much for the opportunity. I want to make sure you can all hear all right. I'll throw my voice. Okay. It's a great honor to be back in Egypt. I too had an Egyptian mentor, Dr. Maria Assad, very pivotal in my life, like Dr. Fatella. And Egypt has been the source of much inspiration. The ICPD was, of course, held here, and this is a modest summary of what I took from it. It pivoted the discourse from positioning women and girls as objects to being subjects and clear stakeholders, and by placing human rights and lived realities and human rights across the life cycle at the center, the Accords fostered analyses of how conventionally configured services and success metrics, which is an important subject, economic planning and societal stereotypes and assumptions about the shape and power dynamics within households had marginalized females, often from birth, and excluded them from meaningful citizenship, social, and economic participation. One of the first international figures to call attention to needing, in order to claim rights, having access to a safe livelihood was Dr. Assis Bandari, who was a minister here of health and population. And Dr. Bandari in the 70s said we have to understand fertility behavior is social behavior, because at that point, coming off a wave of excitement, deserved excitement, about vaccines and so forth, there was still a notion that you could deal with this in an isolated technical way. And certainly Dr. Evans was making a big plea just now for us to contextualize. I'm going to use the time I have to talk a little bit about, where I can, also making reference to Egypt, what the work on adolescent girls and young women, I think, has taught me over this time. And I'm going to present some graphics that I hope will make the broad arguments more understandable. So this is a community. There's your resources on the ground. In even the poorest communities, there are a couple $100,000 sitting on the ground. The boys have not perfect, but more access, including in number of hours and where they can go. The better off girls have some access. And the poorer girls are cut off from access to services, but also means they're cut off to that other essential social participation, social capital building, friendship networks, spaces, and the foundation of livelihoods, because they are both fiscally and through their caregiving supporting younger and older dependents. This is my attempt to do a little bit of a timeline. And my next point is that at each of these points along the side, from the ages going up, are points in which if you do succeed in protecting a right or building an asset, you have to be aware that the female life cycle is full of specific shocks that can deplete and take that asset or that right away. And those have to be planned for. It's not a monotonic investment. So from early risks of traditional body mutilation, school entry, puberty, both social and biological. There have been lots of references to social media and AI. And not only is puberty moving down slowly, it'll have an irreducible minimum, of course, but the point at which girls are being socialized, even sexualized, is moving down in age. The school leaving process and marital instability, conflict, and dissolution. In some summaries here, I know there's reduction in FGM, but as long as it's connected to marriageability, it'll be a struggle. School entry, better. Completion of school, better. Puberty, I think, is still largely a crisis because of the effects on when school leaving takes place, the transition into work. And in terms of marital instability and conflict, I congratulate Egypt on the personal status laws, which I think make a great difference and allow for women to exit from abusive or difficult relationships, but they don't do so without substantial economic penalty. And then on the side there, this is the burden that no one talks about. And this morning, the panel on aging, who is going to look after younger and older dependents? In our program work, we have girls, Syrian refugee girls. I can't go to the program until I fold my brother's clothing. I have to look after my grandmother. The girls, in many cases in the poorest families, are effectively surrogate husbands to their mothers and co-supporters all through their lives. So this dependency burden or dependency ratio is as must be managed, and unless there's a larger planning for it, I think it'll fall on the backs of beginning with young girls all the way through their lives. Girls' social capital is necessary to both claim their reproductive rights, their sexual rights, but also to participate economically. When school dropout accelerates, the interventions must go earlier. I would say in many countries we're talking 10, to make sure that you really begin to support girls' social inclusion just at the point where it will shrink. And this is an example from South Africa, but you can replicate it lots of places. Oh, sorry, back. There we go. These hours, not safely in 16 hours. So you have two dimensions. You have a spatial dimension and you have a time dimension. Collapse of their access to the public space. Collapse of their access to friendship networks. And I have a boy slide too, I don't have time to show. The girls' space is about a sixth of the boys. And then if you multiply it by the number of hours they have available, they have maybe 1/12 the social access. This is to the investment on the ground. We're worried about how money's spent and where it goes. You have unused facilities. You have community centers girls can't go to. Youth centers, you've never seen a girl. Then I must transit to two other thoughts. In that interregnum between school leaving, and Egypt has made great progress in the number of girls completing secondary school, we still don't have a participation in employment, and you often, at the same level that I'll show you that slide in a moment, there's a decline in friendship networks. The first birth, as you know, is the most dangerous birth, and as Egypt's fertility is falling, a higher and higher percentage of the births will be first births. And this is a social moment, not just a perilous physical moment. I would strongly suggest looking into creating young married girls clubs. We did this in Ethiopia, doubled the contraceptive rate, but created peer networks that were stronger, more access to services, combining it with perhaps the establishment of savings accounts because they're unbanked. And this is very telling. this shows the decline rapidly in female participation in private, wage labor. Those females who are in public sector work, there's less of a bump because public sector work has been better adapted to having children. But private sector, they drop out and then they get into self-employment. A lot of stuff happens right here, and the most recent analysis even of public sector work is that there is the younger cohort of females has less, unless they have background wealth factors such as a father that was educated at the secondary level and other SES indicators, they have appreciably less access than those from better off families. So you have two declines. You have the decline in private sector employment at marriage, the marriage penalty, and going into self-employment, which is not as well remunerated, and you have a lessening access to the civil service, public labor, which at one point was a democratizing institution. As to suggestions, we commissioned some time ago these data from Shelley Clark, a colleague of yours, Tim, I think, to look at over the long term, because much of what happens in female lives is that there are cultural mythologies. Most females in the world today will be substantially or solely responsible for themselves and younger and older dependents, not just caregiving, but fiscally. Female income is family income. It's 10 to 20 times more dedicated to all of the benchmarks in the SDGs. Girls are not prepared for this. And it's only a tragedy, as my father said to me, if you're not prepared for it. In other words, there are injustices ahead, but one needs to know. I would hope that the foundational investments we make in girls with two windows, the 10 to 14 is vital, and the youngest first-time wives and mothers, because I think at those inflection points, if we can help them retain their faith in themselves and the skills to claim a resilient life, a life with social connection, and in all fairness, to have some access to and control of resources, that will actually be the best foundation, certainly for Egypt, but for the rest of the world. Thank you.
Thank you so much, Dr. Judy, for this exciting presentation and for keeping the time. I think investing in girls in education and employment is very important intervention to be considered, and it is part of the Egypt policy or population strategy, but maybe you have to think more of materializing it. Last but not least speaker, my dear colleague Dawla Charawi. She is a population and development analyst with UNFPA country office. She has a master's degree in project management from the University of Salford. Please, Dawla.
Thank you very much for the invitation and for giving me the opportunity. Good evening. A lot has happened in the past 3 decades in Egypt. Population has grew from around 60 million in 1990s, 1994 to 106 million today as we speak. So we're talking about 46 million added to the population of Egypt. A lot of progress has took place. We're talking about longevity. People are living longer, which is an opportunity. This is an opportunity. Lots of progress happened with the RH indicators, reduced maternal mortality, improved contraceptive prevalence rate, decreased total fertility. So it's improved access to services, increased demand for the services, which means people are aware. Also, the vaccination coverage when it comes to children, for example, it's improved. When we look at the data, there is also improvement. We're talking about regular census, the conduction of census, We're talking about regular conduction of surveys. We have a very sound in Egypt CRVS system. So it's all moving in the right direction. When it comes to women empowerment, Egypt has did progress in this direction as well. Lots of strategies, legislations, opportunities to women and support services, of course. Also regarding the human rights, we have the National Council for Human Rights. We have a strategy in this regard. Digital access, digital transformation projects that is transforming all the services and all the records to automate and digitalize everything. That's also in progress and it's moving forward. Greater infrastructure, which is an expansion in the inhabitant land from 7% to around 10% or more, maybe 11%. The country is moving towards a comprehensive and a holistic approach when it comes to population. Since population is a multidimensional issue, the government now is approaching it in a multidimensional approach, in an integrated approach, not only focusing on family planning per se, but in addition to that, there is women empowerment, there is data and governance, good governance, there is youth and employment education, of course. And of course, the education enrollment has improved as well. So the human-centered approach that is the basis of the program of action is now fully implemented in Egypt, if we can say that. We witnessed the launching of Bidaya, whereas the focus is on the human beings. The theme of the Congress that we're attending now is also including the human development. So human development, the people, the person, the individual is the focus, and the family, of course, is the focus of our work. We are a youthful population here in Egypt, which is in an aging world. With the decreasing fertility, the window of opportunity to harness the demographic dividend is closer, and we need to pay attention to the required laws, education, to do with education, employment, and empowerment, of course. Governance also is moving forward. Reproductive rights and choices are also on the table. The government also is moving towards decentralization, giving more authorities and responsibilities, of course, and accountability at the governorate level. The localization was initiated a few years here, the SDGs localization, which is a quite innovative approach toward decentralization, disaggregation of data. To address disparities and inequalities, to identify the gaps, and accordingly to plan targeted intervention. On the other side, we have the opportunities, okay, and the progress. We still have the unfinished business, the unfinished agenda. We have challenges, of course, when it comes to implementation. We have low female labor participation, for example. We have inequalities still exists. And when it comes to reproductive health, we're talking about persistent unmet need for family planning, for example. This is one challenge, in addition to, of course, C-section, manpower issues, different issues when it comes to the reproductive health. Also, there is unfamiliar new challenges that we are facing in the country, such as the climate crisis, the digital divide, instabilities surrounding us, also maybe unplanned urbanization sometimes, in addition to the silo style of working. We're still moving towards good governance, we're still moving towards merging and complementarity rather than being there. Yet the core aspirations of the program of action still relevant and continues to inspire all of us to focus on right choices and empowerment. Of course, UNFPA country office stands ready to support Egypt in all its national priorities and in fulfilling the ICPD commitments, and of course the SDGs as well. We're supporting to accelerate the progress through our 11th country program. Of course, more focus will be given regarding acceleration of implementation of the different strategies, the national population strategy, and the different action plans based on this strategy. In addition, of course, to the health, reproductive health strategies and many other the women empowerment strategies. Multiple strategies actually the country is doing, and now maybe the challenge is the implementation and the acceleration of achievement of results.
Thank you, Daulat. This is very useful. I will get to you with a question. We can have a couple of questions from the floor, but also there is questions to be addressed to each panelist. So I will start with the question to be addressed to the panelists, then we'll open the floor for a couple of questions. Dr. Sameera, I know probably you answered this question while you were presenting, but let me listen to it from you. As you know that fertility declined in Egypt over the last 10 years from 3.5 to 2.4. Do you think this qualifies Egypt to achieve a demographic dividend? And what is the priority intervention for Egypt to act on so that we can achieve a sort of demographic dividend?
Thank you. I think achieving the demographic dividend is anyone's guess. Because it's not just about lowering fertility. There are a lot of things that need to happen, and it needs to happen at the right time and at the right moment for the transition to become a dividend. While lowering fertility is a keystone, it's a cornerstone into the entire exercise, but I always say that once the fertility comes down, it's no longer a health agenda. It becomes a social protection agenda, competitiveness in the labor market, education, social norms, girls dropping out of schools, early marriage, FGM. So while it is extremely important to actually lower fertility, but lowering the fertility alone, A, is not a guarantee. B, really there is no roadmap for when this happens. There has to be this cumulative effect of a lot of policies, social policies, to all sort of, come back together, and then the dividend may happen.
Thank you so much. So more investment in education and all kinds of development, together with reducing the fertility, will help us. And I think the acceleration plan, Dr. Abla, is really focusing on those interventions so that we can be on track. Dr. Tem, thank you for this very interesting presentation and for your recommendation or suggestion. I'm wondering, with a youthful population like Egypt, where 60% of the population is like less than 30 years, what is the magic for the health policy in Egypt to take into consideration with that structure of the population?
Thank you for that question. I think first it's very important to recognize that the opportunity to create what I would call salutogenic opportunities for that part of the population, meaning to remain healthy, are incredibly important. And so primary prevention, health promotion, I think are fundamental. So let me be more specific. Anything that can be done to discourage taking up tobacco consumption, an absolute best buy, right? Because as soon as young people get addicted to tobacco or other substances, they're basically charting a course to accelerated chronic disease of one form or another. And those habits are formed at young ages. So I think creating an environment where younger people can make healthy choices is particularly important. Second, I think it's really important to recognize that the more opportunities that segment of the population has, not only to be healthy, but also to be skilled and able to contribute to the economy, not only here, but perhaps elsewhere, is also very important. And I say that because if you look at that demographic bulge in the youth population, you see a demographic atrophy in other parts of the world that are desperate for healthy, well-educated, competent young people. And so those markets are opening up, and there's no reason why Egyptian youth shouldn't perhaps be part of those in ways that are going to provide them opportunities that may not be abundantly available in Egypt given the numbers, but where the global markets are in desperate need of healthy, competent individuals. So those would be two things I think that could be done that would perhaps make sure that that is a demographic dividend, not only currently, but into the future.
Thank you so much, Professor Tim. Dr. Judith, from the lessons learned from the international experience on working on investing in girls' education and employment, do we have like country experience that we learn from it in that area, so that while we are strengthening our population strategies and fine-tuning things while we are implementing it, we can learn from this international experience?
Thank you for the question. And first of all, some of the lessons, the best lessons, were incubated here in Egypt. I think it's essential to, you're doing one thing I think is very positive here, is the localized SDG. The SDGs really need to be moved down and kind of micro-targeting. And when in those communities, focusing on specific segments. The programs I've seen that operate the best have, I'll give you an example from Guatemala. There was many disparities between what they call the Ladino population and the indigenous population. So we took the time to look for the effectively micro-targeting of communities, as you were doing in parts of Upper Egypt and frontiers and so forth. But in there, an additional analysis. You need to give enough content, multi-level content, early enough to threshold proportions. It's very important because you're trying to disrupt both marriage markets and economic access. So if you're whatever place you're in, to get 60%, 80% of the girls, let's say 10 to 14 out of school, or of the first-time youngest mothers, and in most places to get at least 2 segments so that you are a little bit up the pipeline with the girls who are in this puberty moment, but also the girls who may have passed through a bad experience or a hard experience lifetime with child marriage and a child. That density, the density of investment is key. Density of material, density in numbers. It's better, I say to people, in wherever you're working, hit that threshold number, because then you're creating a density of social capital that is much more sustainable. And we have seen, for instance, in the case of the work in Guatemala, that the mentors, who are absolutely essential, are really the female infrastructure. They're the new governance. They help create safe female spaces for learning skills, for playing, which they should be doing from a health and other points of view, and from negotiating power structures for savings and financial literacy. But they also then themselves can be used to extend the programs. They can collect some of the data that people have spoken about here. They can get into those households. They can, during COVID, we had, the mentors could tell you who's hungry. They were young and female. They could go into the households. The mentors had their own operation raising chickens, so therefore they could deliver eggs across. They could get themselves involved. So that density of female infrastructure at the local level, And the economic piece is absolutely vital. Parents are much more interested in having their daughters involved in these programs if they believe that they can join the modern economy. And that's signaled to them by stepwise financial literacy, safe savings, and you have in most all countries the ability to have a savings account at a young age because it's an asset, not a contract. A program in Kenya, we created with a number of banks a product for both males and females, but particularly consequential for females to be able to have a mentored savings account at age 10. You cannot imagine the turnout. Scaling out, not scaling up, going to the right places, dense investment, and then have the mentors and the girls spread out to the adjoining territories. That's the best advice I can give.
Dawlat, you are the population development person in the office, and I see that you mentioned in your presentation that Egypt is doing well regarding the achievement of the program of action of ICPD. What about SDGs? Tell me about SDGs, SDGs localization.
Thank you very much. The SDGs localization means that we take the local context into account while setting the quantitative targets for a number of SDGs indicator. This is what we did a few years back in partnership with the Ministry of Planning and Economic Development, where we selected around 35 indicators, SDGs indicators, and based according to the available data and of course our mandate, we set local targets to each governance based on the baseline of that governorate. And in that exercise, it shows the gap and the disparities between governors. For example, in Port Said, the poverty rate was around 7%, while in Sohag, it was like 66%. This is like 5 years back, but I mean the gap was very obvious and clear. In addition to the engagement of the local governments to understand the SDGs and to start telling us about the priorities and the actual needs, and sometimes they tell us the solutions to solve an issue or proposal. Of course, the budget constraints and the limited resources was always on top of the dialogue, but in the end, still they do have their own solutions and understanding of their needs, and definitely engaging the local governments and the local population is more efficient and effective to find solutions because it's a participatory approach, it's community engagement, it's a closer and accelerated response because they are closer to the people instead of having the people in the margin, they are now in the mainstream. That was the exercise, and afterwards it was taken forward by the Ministry of Planning, and they developed the voluntary local reviews for 3 governorates, and I think it's progressing, and that is very good because now the local governments or the governors, they develop their own reports reporting on the progress towards the SDGs and according to the set targets based on the baseline and the situation when we develop.
So much, Dawlat. Before taking questions from the floor, Dr. Abla, do you have any comment, any question, or you want to say something?
Actually, I'm very happy that I gave my time for our eminent speakers to talk because I learned a lot throughout this panel. And thanks to God, I'm coming out of it feeling that I'm on the proper track. And all our speakers supported our view in the accelerated plan of Egypt. And I'm really asking them all to support me and support the National Population Council and Ministry of Health in our way forward in our accelerated plan, because we hope to achieve our target, not only in reducing the total fertility rate to 2.1, but the more important is improving our indicators regarding poverty, regarding girls to work better and to be involved more and to have all the support regarding our economics. And I was very happy to hear from Dr. Sameera how this plan will invest in our country economics. Actually, is very optimizing, or I feel very, very much supported with what I have heard for the coming plan to achieve. Thank you very much for all your support.
Thank you, Dr. Abla. Because of the shortage, yani, we are almost at the end of the session, but we can still take a question or two from the floor. If anyone wants to say, to have a question, just introduce yourself and have your question, to address your question to the panelists.
Anyone is still awake?
Any? So, if not,
We have a question.
there's a question here.
I have no question. Hello? I have no question. I just have two thoughts, and I know it will open up for another panel, especially with Dr. Sameera. I don't quite know how to put it, but looking at your and listening to you, Dr. Sameera, and from your vantage point of the World Bank and how the government responds to this, of course, I mean, a government hears this and sees your figures. The message that comes out of it, though, is a bit like the Malthusian way on the other side, like a flip side coin. It's basically what I'm hearing is that if you have the less children you are, the richer you become. I know it's much more nuanced than that, and you're using South Korea as an example, and we know that the South Korean government is desperate because they have negative replacement rates to bring in diaspora back. We have the Germans, Chancellor Merkel, who invited 1 million Syrians to come to the country as a gentrification effort for all these qualified workforces that we need. So where migration, ICPD agenda, where migration becomes, it's part of the population dynamics for exactly the other trends, right? So I was hoping, or I was waiting for your medium line. Like, not the extremes, of course, but the medium line where you have to find the right balance. And I'm sure you have that medium line, but I felt your presentation was quite extreme, with all due respect. And my last point is, the second point is about the decentralization and the SDGs and the localizing the SDGs. I was part of the MDG effort with Professor Sachs, and we obviously learned that the SDGs was this step of the world we want and a much more holistic approach to it. But the problem that we're facing is the measuring success, the measuring the indicators, the many indicators that we have in the countries, and the need to decentralize the power of data that we have in the 21st century to measure progress, or where we need to put more effort in as a government. So I think it's really important that we accompany this decentralization or the localization of SDGs with a commensurate capacity development and an instilling of a national culture of statistics, a little bit aligned with Paris 21 agenda, so that we measure success, but we can also correct as we go. And I think Tim, your point on the workforce, the health workforce, and the midwives and others that are at the local level, they will be extremely important data gatherers to keep us on track. And I think those are two thoughts that I have. And Dr. Sameera, I'm sure that you have a lot of responses to that. But thank you so much for this extremely amazing panel.
Thank you, Eve. This is very helpful. I think Sameera wants to say, oh, please, Sameera.
I take your point with a lot of respect, but let's just revisit the semantics of the situation and revisit the assumptions. Egypt has a high fertility rate, which is impacting the social services and the poverty lines. Yes. South Korea managed to reduce its fertility barriers. So did Bangladesh. So did India. Yes or no? Absolutely. To show the Egyptians how to become South Korea. The call is to look at the process by which fertility in South Korea and in Brazil, and anyone who's trained in demographics would know that, it was the social values, it was the persistent public policies and what have you. So the idea of this is not to, we wouldn't in 10 more lives advocate for the one-child policy of China, for example. It's the rights agenda, it's everything agenda. So maybe we need to revisit the presentation, how we presented the curves, but it does say on the title that the rapid the fertility decline in South Korea did this. And then, and we all know also that fertility goes through phases. Like in Egypt, we saw a rebound during the Arab Spring, and then it came back to where it was. So we definitely don't recommend the path of South Korea. Plus, I would like to remind you that there are countries that are way below the replacement ratio without necessarily having those aggressive policy in reducing fertility. Switzerland, the Swiss are going to be extinct in 50 years because the fertility rate is 0.6 something, so you are going to find all the Eastern Europeans in living and working in Switzerland, which is not something bad at the end of the day, with all due respect to the Swiss in my life and not in my life. So the idea is that the comparison is at the process, at the how, not, take what North Korea did and become extinct in 300 years. So that's my 2 cents on the subject, of course.
Thank you. That's it? Okay. Well, at the end of this session, I would like to thank the panelists. Thank you very much for this exciting and fantastic presentations indeed. I would like to thank the audience and thank you all. Thank you so much.
Thank you for your active participation in today's session. We hope the discussions provided valuable insights and inspired new ideas. We look forward to welcoming you back tomorrow for another engaging day of dialogue and collaboration. Thank you.